Morning, General Place. Ladies and gentlemen, I'd like to take the opportunity to thank the SMS Committee for the opportunity to present today, as well as my co-authors listed here and innumerable others who participated in this project over several years and over 4,000 patients on the Mercy. I'll also stay as long as I can on the slide because it's by far the best one of the entire presentation. It has a very nice picture coming into San Diego. No, really, I'll stay on this one. There we go. I do have one disclosure in that my very opinionated views are not yet the official position of the United States Navy or any other government entity. Talking quickly about the global burden of disease as defined by the WHO and using disability-adjusted life years to calculate these values, around 15% of the overall global burden of disease results from trauma. Of the surgical burden of disease, and I'll mention quickly that the surgical burden is more than AIDS, malaria, and several other medical conditions that receive far more funding than any trauma research by a factor of about 10 to 1. But of that surgical burden of disease, 90% of it exists in low and middle income countries as defined by the WHO. Talking about Pacific Partnership, not referring to a trade agreement here, the USNS Mercy is one of the two large hospital ships, the Comfort being the other one operating in the Atlantic and doing some similar missions in the Western Hemisphere. But the Mercy specifically has been providing long-term missions since 2006. On average, it goes out every other year, although Pacific Partnership is a mission which also includes construction projects, dental, medical, and veterinary care, is a yearly experience. However, the experience within trauma has not been previously reported, and in the context of preparing for combat care and defining what cases our staff and staff surgeons and residents are performing both in garrison care and forward deployed, I think this represents a little talked about experience that can add to both of those operative experiences. The methods were fairly straightforward. We prospectively collected all cases that were performed on the Mercy by DoD surgeons. That is relevant only in that the number of cases performed by non-DoD surgeons is very significant. Operation Smile and about 32 other NGOs operate off of the Mercy. We also excluded cases that weren't actually performed on board, which was a smaller number, and we only counted cases that were done while the Mercy was the ship deployed as part of Pacific Partnership, again, on average, every other year. The results are the following. We performed almost 4,000 cases during that decade, and this calculates down to about 68 cases per surgeon, and that's performed over an average of about 4 months, so fairly productive. 7% of the cases were classified as injury-related, most of them in a delayed fashion, but there were several major traumas in the middle of that series that were brought on board as acute casualties. Delayed burn care and operative fixation of fractures represented the majority of the cases being performed for trauma, and the operative volume really didn't change significantly by year, and it did not change by country. When we looked at specific countries that were being revisited, that experience remained fairly stable. In other words, if you're going out on a humanitarian aid mission, you should expect to see trauma both in an acute and delayed fashion. Looking at these values in a little more detail, you'll see that a lot of these procedures were performed by non-general surgeons, but I would argue that 90% plus of the cases could be performed by a general surgeon, especially if we didn't have all of these specific specialties and subspecialties deployed. That's just how the Mercy heads out on these missions, but that doesn't mean that a general surgeon couldn't be doing these, and in most of these cases, general surgeons were involved in the care. You'll also see that breaking down the results into a little bit more detail. Apologize. There we go. The number of cases involved in delayed trauma is certainly more than the numbers involved in acute trauma. But again, looking at specific cases, general surgeons could be performing most of these. In addition, the caseload of the surgeons by subspecialty performing trauma versus non-trauma in most cases, elective operations, orthopedics and plastics really participated very heavily, and general surgery, while the primary surgeon wasn't necessarily involved in all of these, in a support role, every single specialty on board the ship operated in some immediate or delayed fashion on these trauma cases. So in conclusion, these aid missions represent a significant surgical experience and are ongoing. The number of elective cases outnumbers the acute, I'll call it more combat-related trauma cases, but the experience overall has a significant number of really serious injuries, especially some of the delayed burn care and in some cases, year-long cases involving fractures that had gone untreated for months to years in some of these patients. Sequelae of trauma, although not well defined in current WHO statistics, is a significant portion of the global burden of disease as we saw it on the Mercy. And I would argue that education and preparation for receiving these types of casualties that, again, in some cases would not be seen in normal civilian centers here, the preparation for that should be an ongoing mission as we continue this work in the Pacific. So again, I'd like to thank the committee, and I'd be pleased to answer any questions.